All right, let's break down the management of chronic heart failure. We're going to go through it with a really clear step-by-step framework that's perfect for nailing your exams or just sharpening up your clinical skills. So let's just dive right in with a classic scenario. Picture this. Your patient walks in, they've got swollen ankles, they're short of breath. I mean, those are the hallmark signs of volume overload, right? So what's your plan? What do you do step by step? That's exactly what we're going to figure out. Okay, before we even touch on medications, let's get on the same page about the problem. At its core, heart failure just means the heart isn't pumping like it should. Think of it as a failing pump. And because it's failing, fluid starts to back up in the body, which gives us that volume overload, the swollen ankles and breathlessness. Our entire strategy is built around fixing this. So first things first, our number one priority is always symptom control. The patient is feeling awful. They can't breathe comfortably. We have to address that right away, before we even start thinking about long-term stuff. So what's our first move? We've got to tackle that extra fluid. And we do that with a loop diuretic, something like furosemide or bumetanide. These drugs basically tell the kidneys to get rid of extra salt and water. That directly reduces the volume overload and, gives the patient that much-needed relief. Now, this is absolutely crucial, and it's a huge high-yield point for any exam. Loop diuretics? They are fantastic for making patients feel better, but, and this is a big but, they do not improve long-term survival. They are purely for symptom control. You have got to remember that distinction. Okay, so once the patient is breathing easier and feeling a bit more comfortable, our focus completely shifts. We move away from just symptom control and get to the main event, starting the medications that are actually proven to help people with heart failure live longer, healthier lives. And this is the core algorithm, which I like to think of as an escalation ladder. You start with either an ACE inhibitor or a beta blocker. If the symptoms are still hanging around, you just add the other drug to the mix. And if the patient is still symptomatic on both of those, well, that's when you climb to the third step and add an aldosterone antagonist, like spironolactone. Of course, real-life patients rarely follow the textbook perfectly, right? So what happens when you run into common problems or patients with other conditions? Let's troubleshoot a couple of really key scenarios. Here's our really common one you're going to see all the time. Does our plan change if our patient with heart failure also has diabetes? And the answer is a big yes, it absolutely does. While most patients can start with either an ACE inhibitor or a beta blocker, a patient with diabetes must start with an ACE inhibitor. For this group, it is the clear, definitive first-line agent for improving survival. So you're probably asking why? Why is there a special rule here? Well, it's because ACE inhibitors are renoprotective. They literally help protect the kidneys from damage, which, as you know, is a major risk for patients with diabetes. That amazing extra benefit makes them the obvious choice to start with. Okay, let's tackle another really common problem. Your patient is already on all three drugs, the ACE inhibitor, the beta blocker, and spironolactone, but they still have swollen legs. What is that telling you, and what's your next move? What this is screaming at you is that the diuretic just isn't cutting it anymore. So the plan is to escalate their diuretic therapy. First, you just increase the dose of their furosemide. If that doesn't work, you can switch to a more potent diuretic like bumetanide. And if that still doesn't control the swelling, the patient probably needs to be admitted for some IV loop diuretics. All right, we've covered the core pathway and a couple of key exceptions. Let's really lock in this knowledge by going over the most important high-yield points one more time, the stuff you absolutely have to know for your exams and for your practice. So let's really hammer home these final exam pearls you need to know. Let's just run through them quick. Number 1, diuretics for symptoms first, then escalate with ACI, beta blocker, and spironolactone for survival. 2, if the patient is diabetic, ACE inhibitors are always first. Always. 3. If the edema just won't go away, increase the diuretic dose, switch the drug, or admit for IV. 4. Remember, spironolactone does two things. It's mortality reducing and it's potassium sparing. And that leads to number 5, always monitor your electrolytes, especially potassium. So there you have it. What's the big takeaway here? It's that mastering this stepped care approach means you're moving beyond just treating symptoms, and you're truly improving your patient's chances of survival. And really, that's the ultimate goal.